Okay, let's try that again. Hello, everyone. Welcome to our very first virtual poster presentation sponsored by the National Association of Family Nurse Practitioners. We are so very grateful to everyone who submitted an abstract. We had a really good response to this inaugural presentation that we're doing tonight, and thank you all so much for your engagement and your attendance. We are really looking forward to some great speakers and looking at some great presentations and to see how this goes, to see if this is something that we could offer on a more routine basis to not only give you a platform to disseminate the great work that you're doing out across our country as family nurse practitioners, but also a platform to just collaborate and engage with like-minded people. So thank you for being here tonight. I'm Lauren Mays. I'm the co-chair along with Dr. Amy Malcolm here of the Scholarship Committee for the National Association of Family Nurse Practitioners. Sean?
So if you go ahead and advance for me, Lauren, that'd be great. So thank you. I'm Sean Fagan. I've talked with many of you. I appreciate that. One more, Lauren. Thank you. We just want to give you a quick note that we've got a NAFNP membership offer if you're interested. We'll give you 3 free months with a 1-year membership purchase. So we welcome you to try that out. There's a QR code here, and then we'll send you one later if you'd like to become a member. There's a lot of great opportunities, especially if you're a student or a new grad transitioning to practice. There are many great mentoring sessions here that you can utilize to help as you transition to practice. There's also great mentoring and networking opportunities. We have a job center, and you get to be part of the collective voice of the FNPs. And we even offer 12 hours of live continuing education this year, like events like tonight. And then we have national committee opportunities, which is a great opportunity for you to get mentoring and advance your career by working with fellow nurse practitioners. Okay, Lauren, let's get started with the presentations.
You're on mute, Lauren.
First up, we have improving obesity care workflow, process improvement in screening, referrals, and staff collaboration for weight management. Sorry, my keyboard is sensitive. In primary care.
Yes.
Astasia Tassi.
Yes, this is Faiza. So I'm a Rush student for the NAFNP program, graduating spring of 2026. So my project was about obesity management in the primary care and basically focused on improving the workflow, a process map to guide the staff on improving the screening for patients with obesity and kind of bridging those gaps in addressing the obesity in an effective manner. So obesity is really a hot topic these days. I mean, it impacts over 42% of the United States adults. And according to the most recent statistics, if it continues to rise at the same rate, by year 2030, it will approach probably 49%, which means every one of the 2 adults would be obese by that time. And it significantly elevates the risk of chronic diseases. We all know that, and it affects your life expectancy. And it also contributes to the major health expenditure that our country is facing right now. So the project was conducted at a primary care clinic in a suburban Chicago, where 63% of the adult patients were found to have the BMI of greater than 30, yet there was no standardized screening or referral protocol, and the staff reported low knowledge and confidence in managing obesity effectively. So the purpose of this project was to enhance staff knowledge and confidence through a targeted intervention that aimed at improving BMI screening, patient education and counseling, and utilization of referrals to weight management program. The participating staff included the nurse practitioners, nurses, and medical assistants across 2 suburban locations. So we basically use 3 main strategies. The first one definitely was the staff engagement, the stakeholder engagement and training. So that was ensured through an introductory meeting that discussed the need assessments, the gaps identified, the project objectives, the implementation strategies. So and then we also completed a pre-intervention staff surveys to kind of gauge the knowledge and the confidence of the staff in addressing obesity. We also conducted the weekly staff check-ins through the emails. and the monthly staff training sessions that covered the BMI documentation, the newly developed obesity screening process map, and an educational tools to enhance obesity care delivery. And then at the end of the intervention, we also complete the post-intervention surveys to see how that intervention improved the staff knowledge and confidence. So we developed a process map, and then to kind of give you an idea of what process map. So every time a patient came to the clinic, the medical assistant documented the BMI, and anytime the patient's BMI is greater than 30, the nurse, the clinic nurse will go and give a patient an educational handout about healthy eating, physical activity, and lifestyle behavioral modifications. And then once the patient and the nurse, if identifies the patient as a candidate, then they will put an automated referral, like an automated order to refer to the weight management program in the patient system. The process starts with the medical assistant and the nurses. When the nurse practitioner goes to see the patient, just want to make sure that we're still there.
I have no idea what the screen just went blank.
Okay. Yeah.
Let's
So
hang on, I'll reshare
All right.
for you.
So yeah, so when the nurse practitioner goes to see the patient, so they will kind of dig deeper into that educational handout, assess patient's eligibility for the weight management referral, and then assess all those barriers like patient hesitancy or patient's willingness to be referred to the weight management program. So if the patient is willing and they can be benefit with the potential potential referral, the nurse practitioner will sign the order. But that would initiate right when the medical assistant sees the patient, and the nurse puts an automated order under delegated ordering. So the nurse practitioner signs the order and reviews the educational handout and schedule the follow-up. So this newly developed process map guide the staff to screen the patient for obesity, providing them educational handout and referrals to weight management program. Ongoing evaluation and quality improvements, the weekly staff check-ins via emails, electronic health record data tracking, and post-intervention staff surveys supported continuous improvement and outcomes evaluation. So the evaluation of the data showed that a number of the patients that were seen in the clinic in a 12-week period with BMI of greater than 30 were 57. And that amazingly, like 51 of these 57 patients were actually screened using this new process map. So the staff we had a great engagement of the staff, and they actually used this process map to screen at least 51 of these 57 patients. All of them received the weight management counseling in some sort. So the nurse also provide a brief counseling, and the nurse practitioner also provides, so they all receive some sort of like weight management education. 42 of these patients, 57 patients received the educational handouts, but unfortunately only 7 were referred to the weight management program. So that remained pretty low. The staff knowledge and confidence did show some improvement as compared to the pre-intervention and post-intervention staff survey from 80% to 100%. So what this project showed is like the implementation of a structured process map and targeted staff training enhanced the obesity screening and counseling that achieved 90% of the completion rates for the patients with BMI of greater than 30. However, the referral rates remain suboptimal at 15.8%. Short project duration, small sample size, and the documentation variability limited the long-term BMI tracking and generalizability. So we were not able to see the overall BMI reduction in this population. That can be a potential future project to discuss, but we would need a longer tracking time and a larger population to address that. Sustained impact will require extending evaluation, improved referral pathways, continued staff education, and integration of the workflows into routine practice to support scalable, evidence-based obesity care. Thank you.
Wonderful and a relevant topic.
Thank you so much for sharing. We have just a couple minutes for questions. If anyone has any questions related to this poster or to this presenter. And there will also be time at the end as well if you think of things as we move on. Let's see. All right.
One quick question.
Yeah, go ahead.
This is Tracy. Wondering, do we know why there was only 7 referrals? Was that something that was looked at? Is that maybe a future interest to look at why there was only 7 referrals?
That's definitely an important thing to look at, and that would need a little bit more time. But on the preliminary evaluation, I would say many of the times what we face is like patients' insurance barrier issues. Like the patients would say, like, my insurance is not gonna cover that referral to weight management program. So we use a special program that it was like they will take care of the patient's physical activity, behavioral counseling, and they will also consider the patient for the medication-assisted weight loss. But most of the times, the patient's specific insurance were not covering those outside referrals. Other factors that were reported by some patients were like lack of transportation or work schedules, not being able to, accommodate these kind of like appointments with their regular, like if they're coming to the clinic for chronic disease management, that's like probably their biggest focus, but that they would also benefit with the weight loss intervention, but that's probably is not something they can do at that time in terms of like social determinants, so their transportation or work schedule or things like that. So that was like little hesitancy on the patient end.
Got it. Thank you so much.
Thank you.
And in the chat box, it says, great presentation. Any problems with covering weight loss medications?
Definitely, yes. There were so many, because many times I actually personally called some of the insurances to kind of get an idea, but I think obesity many a times by insurance companies covered as is accepted as like a cosmetic reason, not really a medical diagnosis. So unless the patient has a chronic disease and they're like A1C of 10 point something with chronic type 2 diabetes mellitus, and yes, they are obese as well, then they were covered the medication like Ozempic or Trulicity or something, but not specifically just for the BMI of greater than 30. So, but our project was able to yield some data to kind of identify those patients who potentially can be benefited by the medication-assisted weight loss. But yeah, it's definitely, it's still kind of like facing lots of barriers in terms of the insurance coverage, the financial aspect of these things.
Okay, great. Thank you so much.
Thank you.
Thank you so much. Okay, next up we have a school-based mental health program for at-risk adolescents from Sophia Kagan from Rush University College of Nursing. Thank you.
All right, thank you, everyone. So hello, my name is Sophia, and I'm a Doctor of Nursing practice student at Rush University. So this project took place at a tuition-free private elementary school on the west side of Chicago, focusing on 41 middle school students, all with multiple risk factors for anxiety and depression disorders. All of these students have a history of adverse childhood experiences, or ACEs, and additionally, these students have also experienced the COVID pandemic, and they report screen times exceeding 4 hours a day. All of these factors have been associated with increased risk for mental health disorders, particularly anxiety and depression. And recognizing the impact of these concerns, this school aimed to address student mental health more directly.
Yeah, I think we may have lost Sophia. I'm not hearing anything.
If she reconnects, I'll make sure we get her in right away.
Okay. Should we move on to the next presentation?
I would move on and we'll get her back in if she comes back in. Sounds like she was having a, connectivity problem.
Okay, stay tuned, everyone. Moving on.
Okay, designing a blood pressure management system for adult employees of a large urban academic hospital with uncontrolled hypertension. And this is Kaylin Lunneborg from Rush University College of Nursing. Kaylin?
Hi, everyone. Thank you for your time. I'm a recent new grad from Rush, so I just graduated in May, and this is my DNP project. So, introduction to the problem. Hypertension is the leading cause of cardiovascular disease and mortality in the United States. As we all know, healthcare workers are not spared from this. And in fact, they're at higher risk due to occupational stress, poor sleep, irregular working hours, and lifestyle challenges due to this workplace pressure. Despite national calls to action, from the American Heart Association and the U.S. Surgeon General's Call to Action on Hypertension, many healthcare systems lack structured programs to address hypertension amongst their own staff. This is a missed opportunity given the high-risk nature of their work environments and the availability of healthcare workers to receive this type of care in the workplace. This project responds to that gap by designing an evidence-based, person-centered pilot program to support hypertension self-care in healthcare workers through a shared medical appointment design. This is aligned with institutional priorities for chronic disease prevention. So my objectives were to identify at least 3 evidence-based hypertension management programs and design a pilot, including a patient manual, educational materials, inclusion and exclusion criteria, consent forms, and a training guide for the future leaders of this program. This is guided by the REAIM framework. My methods included a literature review. This was comprehensive and completed with the assistance of several academic librarians using the Scopus and PubMed databases, using several search terms I've listed below. This yielded about 1,500 results, 20 of them deemed relevant to this project, and I gathered key data points, put them in an Excel chart to compare themes, and used this to determine the program duration and frequency of the group classes, the group size, inclusion and exclusion criteria, the consent process, curriculum components, and participant materials. There were several high yield programs out of the 20 I mentioned above, and I just listed them below because they deserved special recognition for their impact. The results were a program was designed, the manual was created along with educational materials, HIPAA waiver, criteria, and consent forms. And then I included just this table as a brief overview of that manual I mentioned. It has key program elements related to hypertension lifestyle management, including blood pressure monitoring, medication adherence, diet, physical activity, stress management, and substance use reduction. This is over 8 weeks, weekly sessions, and there was one pre-program, session 0, to make sure patients were on board before going through this program and able to complete consent forms. And then conclusion, a structured hypertension self-care program for healthcare employees has been developed. Stakeholder feedback was positive, and all program materials were approved for pilot implementation. This program is designed to address the high burden of uncontrolled hypertension in the United States, where nearly half of adults are affected, yet only about a quarter achieve adequate blood pressure control. Phase 2 of this initiative will involve piloting a program with 5 to 15 healthcare employees across 8 weekly sessions, using the manual, the training guide, and the other things I mentioned to guide implementation and ensure fidelity. The next phase will assess feasibility, participant engagement, and preliminary outcomes with the goal of informing future program refinement and scalability. Thank you so much.
Thank you so much, Kaylin. What an interesting topic. I wonder if do we have a second for a question? Can I ask a question? As I was listening, I wondered if any of your literature review that you found, did they talk at all about using telehealth?
Yeah. Many of them were telehealth. Yeah, that was something I was interested in, and I think could be included in future pilots. It just was a lot more to take on to also offer it virtually as well as in person, but I think that's a great idea.
Yeah, great. Thank you so much, Kaylin.
Thank you.
Lauren, I think Sophia might be back on unless anybody else have any questions for Kaylin? Don't see anything in the chat.
Sophia, are you able to pick up where you left off? Is she with us?
Hi, yeah, sorry, I had some Wi-Fi issues, so I had to move around.
That's
Nope.
fine. We can pivot. You're fine. We'll just pick up where you left off if you can.
Thank you, I appreciate it. Okay, all right. All right, I'll just pick up from my objectives if that's okay with everyone. So the project, the school-based mental health program, circling back in here, the project had 3 primary objectives. The first was to develop a mental health workflow to guide staff in responding to students with more concerning mental health symptoms. The second was to integrate a structured mental health promotion program called the Creating Opportunities for Personal Empowerment, or COPE program, into the school's existing health curriculum. And the third was to deliver a teacher education session to improve staff knowledge around mental health risk factors, symptom and positive mental health promotion interventions.
I think we may have lost Sophia again. I hope she's not having storms where she is. Shall we keep going and maybe she'll be able to get back on? Or shall we leave her poster up for a minute?
She looks like she's still in the meeting, so
Okay.
I don't.
Can you guys still hear me? I'm so sorry.
There you go. You're back.
No, I can hear you now. There you are.
Okay. All right. 3rd time's the charm, right? All right. So for the framework, we use the REAIM framework for project evaluation to focus on practical application and long-term sustainability, which are both critical for an educational setting with limited resources. For the methods of the project, it kind of divided into the 3 phases based on the objectives. So for the first phase, we collaborated with school leadership to develop a standardized mental health response workflow, which included a clear decision tree, red flag mental health symptoms, and a list of resources for local and national mental health services. The QR code in the center of the poster would direct to that if anyone's interested. The staff are now using it as a reference for managing mental health concerns, as it standardized some previous practices that were already implemented, but also formalized the process and added some additional steps. The second phase of the project, the school's health instructor completed the COPE-specific instructor training and led the 7-session program in weekly sessions with the 6th and 7th graders. Each week, the session was evaluated with the instructor, and these evaluations revealed 2 main themes. The first was that students tended to struggle with the workbook-heavy format, and this engagement was a bit of a challenge. And the second was that engagement improved significantly when students were given opportunities to practice the COPE activities in a practical way, such as with mindfulness and deep breathing. For the third phase of the project, we conducted an educational session for the teachers. This session covered topics specifically ACEs, depression and anxiety symptoms in youth, and an overview of the COPE program that was implemented in the health class, as well as the positive effects of benevolent childhood experiences, many of which can be facilitated by school teachers and staff, and have positive effects on students with histories of ACEs. Pre and post survey results are shown in the graph at the bottom center of the chart of the poster. And there was a mean increase in 28% in mental health knowledge among the teachers. The session was attended by 100% of staff and administrators, and it was followed by a very productive discussion. So overall, this project sort of provided a multifaceted approach to increase school-wide awareness of adolescent mental health needs, and it showed that low-cost, evidence-based interventions can be implemented with existing staff. Key recommendations from this project included, firstly, adapting the delivery of mental health programming to include more hands-on skills-based learning, which would better match the students' learning preferences. The second was to sustain teacher education through annual professional development and including mental health and trauma-informed care as part of their annual learning. The school has already taken steps towards sustainability by contracting with a trauma-informed behavioral health education specialist who is now providing ongoing training for the teachers. So in summary, this initiative empowered both students and staff with tools to recognize and address the mental health challenges, particularly in adolescents. It reinforced the importance of integrating mental health promotion into core school practices as essential to student success and part of the existing curriculum. To conclude, I would like to thank everyone involved with this project and thank my academic mentors for their support. And the QR code at the bottom of the poster links to all references. Thank you.
Thank you, Sophia. You don't hear many projects where you get 100% participation. Great. That's wonderful.
I know. Yes, it was very fortunate and took a bit of planning and strategizing, but it's also a small school, so the population size helped for the teachers at least. But yes, it was great to have all of them involved and all of them really participate in the discussion, which was really, really satisfying to see.
Yeah, there's a question in the chat. It says, great project. How did you gain their support?
So that's a great question. So this was kind of an ongoing concern. So the school, it's run as a nonprofit. It's a private school. It doesn't charge tuition. And really everyone involved, particularly the school leaders, are very mission driven, which made this sort of easy to gain their support. And they've experienced a lot of behavioral issues with the students, emotional issues, and then of course, just getting to know the families. They've understood a lot of the adverse childhood experiences that these students are dealing with when they come to school every day. And so understanding, they already had sort of an idea that this was causing a problem with mental health, but didn't really quite know what a good strategy to implement might be. And so we discussed and came up with this project, and they were fully on board. And it's great to see them taking steps to sustain these efforts too.
Great, and we have another question from Vera Gibb. Sorry, I didn't say who asked the other question. Have you faced any resentment from anybody because of the sensitive topic and stigma of ACEs?
Thankfully in this population, no. I think particularly because the work that the health instructor did with the students was just the COPE program is a cognitive behavioral therapy mental health promotion program. So it wasn't a large group discussion about, trauma or anything like that among middle school students. So it was just kind of focused on health promotion rather than like general mental health promotion. And then with the trauma, the teachers and the staff are all very well aware of these student situations and understand that it has effects on their academic performance, their emotional well-being, their relationships, their behavior, et cetera. So it really became, approached, I think, also as a health professional kind of coming in, had a little bit of a positive impact. And really, I was grateful to be in a setting where I didn't face any opposition or challenges with that.
Thank you, Sophia, for sharing. I really appreciate that trauma-informed approach. It seems like individuals don't realize how widespread use of trauma-informed approaches can be applied. So this is a great example of utilizing that trauma-informed approach through this COPE delivery program. Thank you for sharing. Is there any additional questions before we move to the next speaker?
This is Sean. I just wanted to say congratulations on a really professional presentation under very difficult circumstances, because I know that's not easy. So good job.
Thank you, Sean. I appreciate it. Apologies for the connectivity issues. I appreciate everyone's patience.
Okay, next up we have utilization of postoperative management protocol in decreasing postoperative tonsillectomy and adenoidectomy pain and subsequent emergency department return visits in pediatric patients ages 3 to 17 years. We have Michaela Gilman, Kelsey McClendon, Krista Neary, and Megan Weaver from University of Alabama at Birmingham School of Nursing. Welcome.
Hi, everyone. We would like to thank you all for allowing us the opportunity to present our project. It focuses on reducing postoperative pain and emergency department visits following tonsillectomy and adenoidectomy, or TNA, procedures in pediatric patients ages 3 to 17 at Children's of Alabama. TNA surgeries are among the most common pediatric surgeries in the US, with approximately 500,000 performed annually on patients under 15 years old. These procedures often lead to significant pain lasting 6 to 7 days postoperatively, which can result in increased emergency department visits, parental anxiety, and higher healthcare costs. Recognizing this challenge, our team saw an opportunity to improve patient outcomes through a structured quality improvement initiative.
The purpose of our quality improvement project was to implement a structured pre- and post-operative management protocol aimed at reducing ED visits due to pain and pain-related complications after TNA surgeries. In the plan phase, we identified gaps in pain control, education, and support for families. To address this, we developed a comprehensive educational pamphlet that included medication timing, hydration strategies, non-pharmacologic pain management techniques, and guidance on when to seek medical attention. The material was designed to be clear, visual, and accessible for caregivers of all literacy levels.
During the due phase, we collaborated with the clinic staff to distribute the educational bundle that we created during preoperative appointments. Our nurses at the clinic provided in-person education alongside with the pamphlet we created to reinforce understanding and answer any questions that these caregivers had. In the study phase, we began analyzing outcomes such as postoperative ED visit rates and caregiver-reported pain management effectiveness. At this time, the data collection and the analysis is ongoing. We just ended our project actually yesterday on June 9th, and we are continuing to evaluate feedback from both families and staff. Our early impressions have been positive, indicating that the intervention may be improving confidence in home management for these TNA patients.
So our results are still being analyzed. We believe our project holds a strong potential to improve postoperative experiences for both patients and families. From an implication standpoint, the protocol is designed to enhance pain management, reduce preventable ED visits, and empower those caregivers. It also requires only a small time investment from the staff and has minimal cost, especially when compared to the cost of an emergency department visit. In terms of sustainability, the educational pamphlet can be updated over time to reflect best practices and be continued to integrate into different preoperative care. Our goal is to build a lasting impact through a simple intervention. Thank you for your time.
Thank you.
Great job. Yeah.
Are there any questions for this group of students?
I can't wait to hear your results.
Yeah, that's exciting. Yesterday.
Yeah.
There is a question in the chat. It says, great job, ladies. What prompted the study?
I actually work in the ENT clinic, and I have for the past 2.5 years. And prior to that, I worked 2 years in children's ED. So when I moved to the ENT clinic, they had a standardized sheet that went over education about TNA recovery, but I noticed a lot of it was not in depth and maybe provided not as much information as caregivers may need, especially for patients that are like nonverbal or unable to communicate their pain. So in our pamphlet, we added like nonverbal signs of pain, things like that, in hopes that we can reach a greater community of patients and hopefully keep those patients out of the ED and out of hospital admissions for unmanaged postoperative pain.
Tedra Smith also has a question in the chat. She says, do you have data on the number of ED visits?
We pulled from Epic between our busiest times are Thanksgiving break and summer break for tonsillectomy and adenoidectomy, just because of the long recovery period. And we pulled numbers from the past Thanksgiving Christmas break time, and we had over 300 TNAs, and about 6.7 of those did end up in the emergency department for unmanaged pain or dehydration or pain complications.
He said, thank you. Lonnie Hall said, thank you for your excellent insight related to the young surgery patients, which is traumatic. And as a parent of a child with autism, thank you for including the nonverbal population. That's very important for parents to feel more empowered. And I have to give you all kudos, because sometimes when you have a group presenting, sometimes there's maybe a lag in between. You guys were point on. One stop, the next one, you could tell y'all been practicing this. Good job.
Thank you so much.
All right, thank y'all. Moving on.
Mitigation of race-based antihypertensive prescribing. Dr. Mays, yeah, this is Victoria, but I think somebody called you Tori. Is that what you go by?
Yeah.
And I didn't hear the
pronunciation.
I didn't hear the pronunciation of your last name, so I'm going to let you say it. But you're from Rush University College of Nursing, and we welcome you.
Thank you. My name is Victoria Scacia, and I am an FNP DNP candidate in spring of 2026 at Rush University College of Nursing. My project is titled The Mitigation of Race-Based Antihypertensive Prescribing. So starting with a little bit of background, the guidelines for the management of hypertension in Black patients is historically divergent when compared with patients who do not self-identify as Black. Black patients are preferentially prescribed thiazide diuretics and calcium channel blockers as initial single-agent therapy in lieu of ACE inhibitors and ARBs. Unfortunately, these practices are in alignment with current clinical guidelines from multiple national organizations, including the American Heart Association. These clinical guidelines are informed by antiquated landmark clinical trials, most notably the ALLHAT and the AASK trials, whose validity and results have come into question recently, citing poor study design and implicit assumptions regarding race as biological rather than a social construct, which has interfered with data analysis and generalizability of the results. In 2022, a former DNP students project found that nearly 50% of providers at a large urban academic medical center are consistently considering race when deciding which antihypertensive to prescribe. So the purpose of my project was to build upon the results of this 2022 DNP project to develop, implement, and evaluate an educational tool to deliver evidence-based, race-neutral recommendations for antihypertensive prescribing to a cohort of internal medicine residents. Currently, the site's internal medicine residency program does not include didactic sessions devoted to the role of race in medicine, nor antihypertensive prescribing more broadly. The education aimed to bolster knowledge and awareness of the antiquated use of race in antihypertensive prescribing and in medicine more broadly. The intervention consisted of an adapted curriculum called the Educational Toolkit, which was administered to 102 internal medicine residents, PGY 1 through 3. In our results, we found that half of the residents reported being unaware of the race-based considerations within the current AHA and JNC hypertension guidelines, and nearly 70% were unaware of the ALLHAT or the AASK trials. The residents were asked to review clinical vignettes of a Black, Asian, and white patient with hypertension and select an appropriate monotherapy option. And that is displayed in like the pie chart on the graph. When prescribing for a Black male, 63% of responses selected either a calcium channel blocker or a thiazide diuretic. When they were asked to expand upon their decision, 47% of the responses included an explicit mention of the patient's race, making the calcium channel blocker or the thiazide diuretic the preferred option. On the graph below that, you can see that pretest survey findings demonstrated that more than 50% of the residents either agreed or were neutral in their belief that race is an important factor in deciding which antihypertensive to prescribe. And then following our intervention, more than 88% of the residents either disagreed or strongly disagreed with this sentiment. So from an implications and discussion standpoint, our pretest surveys re-demonstrated a reliance on race when selecting antihypertensives among our target audience. On post-test surveys, 86% of the residents reported an increased comfortability discussing the concept and outcomes of race-based medicine with patients, peers, and their precepting attendings. Over 80% of the residents reported an improved understanding of race-based medicine. And ultimately, more than 90% of the residents either strongly agreed or agreed that they plan to eliminate the use of race when prescribing antihypertensives. From a sustainability standpoint, we are currently in the process of integrating our race and medicine curricula into the 2025 internal medicine residency rotation. And we're planning to expand awareness to other topics outside of antihypertensive prescribing, most notably PFTs and DEXA scans. And in conclusion, a large gap definitely still exists between research, recommendations, practice, and control of hypertension in the United States, especially for individuals of color. In 2020, the American Heart Association released a statement acknowledging the role of structural racism in cardiovascular disease, but failed to provide updated clinical guidelines supporting this call to action. So please join me in this effort by seeking out opportunities to get involved in local anti-racism committees and initiatives within your own areas of practice or within your own institutions. Thank you.
Wonderful. Thank you so much. It's so important when we I see so many DNP projects that people do and then nobody ever does anything else with them. So it's refreshing to see somebody pick up the ball and keep going. So I really commend you on that. This is a great topic. Do we have anybody have any comments or questions? I'm sorry, Tori, I cut you off.
Oh no, that's it's okay. I was just gonna say a big goal of mine in deciding what I wanted to do was that I definitely wanted it to be something that would be sustainable, and kind of seeing those next steps take place. We just had a meeting like last week, and being able to really integrate this into the curricula and have it being a standing piece that all of the residents at this site will receive, I think is really important. And being able to kind of see that expanded use too, like, PFTs have such a huge, there's a big race-based consideration and mindset that has been used with PFTs in the past. So I think kind of bringing some of that to awareness and expanding this beyond antihypertensive is really important too.
Yeah, that's great. We also have a comment in the chat from Valerie Moore. She said, very nice project. Hope we can move the focus to personalized care and not race-focused care.
Yes, definitely agree.
Do we have any other questions or comments?
Mine was just a comment. I was going to say that we're also going to try and have Tori publish this too. So as many people in this presentation day should consider that this is the first step of doing your presentation, and then this can be disseminated yet another way by doing a publication. So Tori knows that, we've talked about that already. And so I'm going to continue to encourage everybody to think about that for your, next step with scholarship too.
Definitely.
Great point, Dr. O'Brien. And the scholarship committee has something up their sleeve to hopefully help transition from poster to publication. So stay tuned for that. Another reason that we would encourage you to become a member of our awesome organization is for opportunities such as that. So thank you for bringing that up.
All right, thank you. Before I read the next one, I'm going to take a point of privilege because I forgot to mention, I want to tell the Education Committee, thank you so much for their collaboration on this project. If you're not part of NAFNP, we all work together really well. That's one thing that we do really well together, and so they helped us out a lot. And so I want to make sure and tell them we are very grateful to everything that they did to help us with the project. We have a lot of comments over there, Tori, for you. Very good work, interesting project, great work, Victoria. Okay, next up we have the impact of a standardized transabdominal plain block preoperative education protocol for abdominal surgeries on patient experience and postoperative pain. Madison Askew, Alessandra Mangione, I'm sorry if I say your names wrong, Haley Shawron, and Reese Weaver from University of Alabama at Birmingham School of Nursing. Welcome.
Hello, thank you so much for having my team and I here tonight. So our project site took place at the Tuscaloosa Surgical Center, which, like many sites, is seeing increasing numbers of outpatient surgeries just due to convenience and cost effectiveness. Specifically, our site is doing abdominal surgeries. The problem, however, with outpatient surgeries, based on our literature review, is that they're associated with decreased time dedicated to patient education, just due to the quick pace of these, in and out visits. So our specific topic that we picked was the TAP block, the transabdominal plane block, which is a regional anesthesia technique that is used for these abdominal surgeries. It helps to provide them post-operative pain relief and thereby decrease their post-operative opioid use. The problem, though, with these outpatient surgeries and decreased education is that the patients aren't receiving enough education on the TAP blocks, so they're making uninformed, quick decisions as to whether or not they want it. Oftentimes they don't want it because they don't know enough about it. So then we're seeing large amounts of opioids being used post-operatively, high pain scores, decreased patient satisfaction because they're in all this pain post-operatively that they were not aware of. And if they didn't get the TAP block, they are not receiving those benefits. So the purpose of our quality improvement project was to try to increase patient satisfaction while also decreasing postoperative pain for these abdominal surgery patients by implementing an evidence-based education protocol. And so our PICO question was to compare the two. Does the standardized patient education protocol on the TAP blocks compared to the usual care, not getting the educational pamphlet, improve patient satisfaction and post-operative pain over a 3-month period?
And then implementation of this educational protocol focuses on 3 key components, and they're all shown there with the little arrows. First, an educational pamphlet on TAP blocks is given to patients by the operating surgeon at their pre-admission appointment. It explains the who, what, where, when, why, and how of the procedure. And then on the day of surgery, the anesthesiologist reviews this pamphlet with the patient and confirms understanding while they're getting consent. Second, assigned nurses provide a Likert scale survey post-operatively with instructions to complete it within 24 hours. And this survey assesses patients' familiarity with TAP blocks, their sense of preparedness, and then the quality of communication with their providers. And then third, a staff checklist is added to patient charts to ensure each team member is fulfilling their role in delivering consistent, thorough education. And inclusion criteria for the protocol are patients aged 18 or older, English speaking, and scheduled for abdominal surgery during the study timeframe.
So the primary implication for our project is to increase patient satisfaction. And with this accomplished, our team proposes that patients will be more likely to use the surgery center again or refer it to others. And then this will contribute to an increase in revenue for the surgical center and lead to long-term facility success. Additionally, we believe that a more educated patient will understand the role that a TAP block plays in postoperative recovery, thus needing a lower amount of narcotics. And then with decreased narcotic use, we will see a reduction of adverse events such as patient falls. These points aid in project sustainability as pamphlet production is a relatively low-cost intervention compared to costs associated with postoperative medications and those associated adverse events.
So to analyze the pre and post implementation data, we use descriptive statistics and t-tests. For average opioid usage of oxycodone, Dilaudid, Demerol, morphine, Toradol, and Norco, and average numeric pain scores on a 0 to 10 scale were analyzed pre and post implementation. Post implementation, the usage of oxycodone, Dilaudid, and Norco and numeric pain scores all decreased, with an average pain score of 1.7 out of 10. The Likert survey data from the post implementation group could obtain a maximum score of 50, signifying that patients strongly agree that they learned helpful information about TAP blocks from the pamphlet, what their recovery would look like, the absence of stress before and after surgery, and if pain was easily controlled postoperatively. With the implementation of our TAP block pamphlet, the average survey score was 47, with scores ranging from 43 to 50. That concludes our presentation.
Great job. Another group that was right on. I can say I've had a surgery with the TAP block, and they are wonderful. The anesthesiologist didn't give me a whole lot of education on it. I knew a little bit about it before the surgery. So, but yeah, I agree. They don't do as good a job as they could educating people on that.
Are there
any
questions for this group?
Well, this is Sean, and before you move on, is the only non-clinical person on there, I have to say it was incredibly easy for me to follow, even being a very highly advanced clinical topic. So that's an accomplishment.
Thank you.
Wonderful job. Wonderful job. Okay. Next up, we have increasing competencies regarding the health risk screening tool among staff working with individuals with intellectual and developmental disabilities, from Stephanie Renzish. I think I said your name right, from Rush University. Welcome.
Hi, thank you. Can you hear me?
Yes, we can.
Okay, great. My name is Stephanie Rancic. I'm a recent DNP graduate and currently preparing to take the FNP board exam. The title of my presentation is Increasing Competencies Regarding the Health Risk Screening Tool Among Staff Working with Individuals with Intellectual and Developmental Disabilities. And throughout my presentation, I'll be referring to individuals with intellectual and developmental disabilities as those with IDD. Some background about the health risk screening tool. It's also called the HRST for short. It was created to improve the health of individuals with IDD by screening for health risk and destabilization in this population. The screening tool is required by the Illinois Division of Developmental Disabilities to be completed for adults with IDD that live in community living arrangements. The HRST generates a healthcare level, or HCL, for each individual screened, which correlates with their risk for health destabilization. And the screening tool also provides individualized service and training considerations for those screened. So the problem that was identified during this project was that at an agency that cares for and provides housing for individuals with IDD, a pre-survey found that 45% of frontline staff were not aware of the screening tool, and 47% were not aware of what a healthcare level is. Additionally, the agency had no standardized process in place when individuals were screened using the HRST and found to have a healthcare level of moderate risk or greater. So the purpose of this project was to increase knowledge about the HRST among frontline staff, workflow skills regarding communicating individuals found to have an elevated healthcare level, and proactive behaviors by staff prioritizing and implementing action steps for those individuals. A little bit about the environment at which this project took place. It was a nonprofit agency that provides housing for 110 adults with IDD located in the west and south side neighborhoods of Chicago, Illinois. The adults with IDD residing in housing through this agency are referred to as persons served, and they receive 24-hour care by the agency's frontline staff. Process objectives for the project involved implementing a new standardized HRST workflow design. At this agency, nurses are the ones responsible for completing the HRST for the person served. So the new workflow design involved a nurse initiating a healthcare level communication form when a person served was found to have a healthcare level of 3 or greater. The goal was to educate 100% of nursing staff on the new workflow and 75% of frontline staff on the HRST as well as the new workflow. Additional process objectives were created to measure the success of staff implementing the workflow design. The outcome objectives and goals of the project were to see a 25% increase in staff knowledge regarding the HRST and healthcare levels, and for 80% of staff to be satisfied with the new HRST workflow design. Methods and results through education sessions held by myself, 100% of nurses and 67% of frontline staff were educated on the HRST and the new standardized HRST workflow design during staff meetings. 6 persons served with a healthcare level of 3 or greater were chosen to implement the new standardized HRST workflow design with, as well as initiate a healthcare level communication form. And the form had nurses write down the person's served healthcare level, as well as select 3 of the recommended action steps from the HRST as priority interventions. Unfortunately, many of the process objectives were not met, and that was due to staff turnover within the agency during the timeline of the project. Sufficient staffing was the resource that most impacted the work this project set out to do. There is currently a nationwide crisis regarding turnover and shortages of direct support staff caring for individuals with IDD. However, a strength of the project was that there was an increase found in knowledge regarding the HRST and healthcare levels among staff. And of the staff that answered the post survey, 100% were satisfied with the new workflow design. So recommendations for future projects warrant investigating factors affecting frequent staff turnover as well as improving retention. And to promote the sustainability of the project, all new staff should be educated on the HRST and the standardized HRST workflow design during their orientation. The new HRST workflow design that was created during this project is also a tool that similar agencies could use to increase the competencies of staff at their agency regarding the HRST. And I would just like to thank Dr. Bridget O'Brien, Ola Abayomi, and Dr. Sarah Ailey for their contributions in serving as additional authors.
Wonderful. Thank you, Dr. Rancich. Congratulations on a great project.
Thank you so much.
Do we have any questions for Stephanie? I don't see any in the chat.
This is Sean. I'd be curious if you considered any opportunities to to overcome that staffing issue with the training. Did you find anything out that would help train people in as they come in, maybe on a shorter term basis?
Yeah, unfortunately, it is like a nationwide problem. And so actually, finding ways to increase retention for people in these positions is a larger problem. But what I did at this agency to promote sustainability is I provided a binder with all of the documents from the education sessions and all of the different, like the workflow design printed out, easy to follow, as well as the healthcare level communication forms. And I gave that physical binder to the head of nursing at the agency. And then I also emailed virtual copies to stakeholders so that they can hopefully use that when they hire new staff to educate them.
Wonderful. Thank you.
Yes, thank you so much for your presentation. Thank you to all of our presenters for all of your wonderful presentations tonight. We do have one other slide. We're just under the hour. So, Sean?
So congratulations to everybody. Thank you for all your hard work. I know from communicating with you many times what level of effort you put in just to the presentation tonight, to say nothing for the countless hours you've put into your projects, which are clearly evident. We wanted to let you know, in honor of this special first time event, we've done a first time membership discount. We'll give you 3 free months with a 1-year membership. So there's a QR code you're welcome to use. We hope you'll become a member. We're really impressed with the work that you've done, and we think that you can make great contributions to NAFNP as an organization. I also want to take this opportunity to mention that the leadership of NAFNP has decided, based in part on the quality of the work that we saw in this project, the virtual poster session, that we think that there's an opportunity for there to be a student committee, a student-oriented committee, which would be a way to bring students into the organization and help you connect to other parts of the other committees within the organization that'll give you some advancement opportunities and an opportunity to continue to work with people like Dr. Mays and Dr. Malcolm, and certainly, Dr. O'Brien, for example, get you an opportunity to be exposed to some other people who can help mentor and help you develop. So we'd like to extend that opportunity for you and welcome you to do that. We will send you a link. Also, I wanted to tell you, if you want to share this event with your colleagues, you're welcome to do that. This is an event we decided to make open to everybody with the hope that they would get to see the kind of work that we do, and also the kind of work that our members do. So there is a YouTube channel that has your presentations on. We'll share the link for that. This will go on there as well once we have it back from Zoom, and then you can share that. And it will also reside on a page on the NAFNP website that's open to the public. That has your bios and the pre-recorded presentation. So that's it from us. Thank you very much. We're going to turn off the recording now, and then we're going to give you your QR code. I'm sorry, your code for the CE.